The implicit guide surgical system is used to perform a trampoline platysmoplasty either as a standalone procedure or in conjunction with other facelift or neck lift procedures. The doctor will examine the patient immediately prior to surgery to confirm neck anatomy. Assessing fat deposits, sagging muscles, and glands is necessary, as well as noting visible platysmal bands and fat deposits. All of these are marked with a surgical marking pin. The operative technique is very similar to that of liposuction of the neck. When used in conjunction with a facelift, the area underneath the neckline is infiltrated with the tumescent fluid and tunneling is provided with a liposuction cannula. If fat is present, it is removed in the traditional fashion. Ultrasonic liposuction can be performed as well. After tunneling the area underneath the skin and removing the excess fat, the subcutaneous area has been opened. The liposuction and tunneling is performed through a 3 mm puncture just underneath the submentum. The determination of the midpoint of the chin is done by observing the space between the upper front incisors. Pivot points are marked along the jawline using the iGuide marking tape. Applying the marking tape to the chin after peeling off the backing and applying the arrow to this region allows the midline placement of the tape. Each circle and alternating line is then stenciled with a marking pin. Several other puncture sites are marked underneath the jawline as well. The first site is the point corresponding with the cervical mental angle in the midline. 2 to 3 other sites are marked as well that represent pivot points for the threading rod. The next step requires the puncturing of the skin. Using the iGuide puncture device, each puncture site is developed by placing the puncture device in this region. Using the other hand, the skin is lifted up as the puncture device creates each pivot point. The dermal clearing device is then used to clear the dermal attachments around each puncture site. This allows the easy insertion and removal of the threading rod without catching any of the dermal attachments. By placing the clearing device in each puncture site and rotating it clockwise 2 to 3 turns, all the dermal attachments will be removed. The suture rods, once docked with the light handle, will activate the light source, thus illuminating the tip of the suture rod. The suture matrix is then built by initially inserting the suture rod in the puncture site corresponding with the midline at the cervical mental angle. Threading the rod just underneath the skin reveals a transillumination of a yellow light corresponding with the subcutaneous fat. If the tip is directed too deeply, the surgeon will see a red, dull light transilluminating through the skin. This gives the surgeon indication that the tip needs to be brought out and transferred and passed more superficially. The tip is then passed underneath the jawline towards the other side to the first vertical line puncture site. Once the rod is brought out through this puncture site, the rod is carefully withdrawn until 1 centimeter of the rod remains in the subcutaneous space. The rod is then brought down towards the feet, thus rotating the tip, which is in the subcutaneous space, cephalad. The tip is then oriented towards the medial canthus. The tip is then advanced 1 centimeter, thus allowing it to encircle the ligaments. It is then rotated upwards, allowing the tip to rotate underneath the jawline. This passage of the suture rod allows the suture to be weaved in and around the ligamentous attachments of the skin to the underlying platysma muscle. The rod is then brought across the midline and is brought out through a pivot point, and the rod is rotated, allowing it to pass to the other side of the jaw to the next vertical line. The rod is brought out in the same fashion with 1 centimeter remaining in the subcutaneous space. The rod is then oriented so that it is directed towards the medial canthus and it is advanced 1 centimeter, thus allowing it to encircle the retaining ligaments of the mandible. The rod is then passed underneath the jawline towards the other side to the next vertical line. This process allows the passage of the suture to the alternating vertical lines, which is very similar to the threading of a shoelace. The single strand is then brought forward to the submental crease in a crisscross fashion and then is brought out through the midline puncture site. The other suture rod is then grasped and carefully docked into the light source. It is then inserted into the puncture at the cervical mental angle and is directed toward the contralateral side of the mandibular angle. This puncture site is marked with a circle. The rod is then carefully weaved in a crisscross fashion towards the anterior mentum to each corresponding circular mark, which corresponds to every other puncture. Once the suture reaches the submentum, there are 2 suture strands which are carefully drawn out through this incision. Both suture strands are carefully tightened. The securing of the matrix requires tension being applied to both suture ends as gentle upward pressure is applied to the area under the chin. Upon reaching adequate tension, there will be visible tension lines from each crisscrossing suture that has been placed with the suture rod. Using a surgeon's knot, the matrix is then secured in place by tying the 2 suture ends which exit just underneath the midline of the chin. Once complete, the sutures are cut and the knot will withdraw inside the incision. Upon completion, the submental incision is closed with a single 6-0 fast-absorbing plain gut suture.